Diabetes care can be challenging, it can be hard, and just that continuous care can be stressful. Children and adolescents and adults can have diabetes and live amazing, fruitful, active, enjoyable lives.
Okay, hello everyone, this is the Diabetes Roundtable. Thank you all for tuning in. I'm Abi.
And I'm Caden.
And today we're joined by Dr. Chris Carpenter, Professor of Pediatrics at UCSF and a pediatric hospitalist at UCSF Benioff Children's Hospital. Dr. Carpenter specializes in caring for hospitalized children and adolescents, and he's focused his global health career on caring for patients with type 1 diabetes. He works at the K. Mackinson Clinic in Haiti and focuses on helping young patients and their families navigate the challenge of living with diabetes. In addition to his clinical practice, he's dedicated to educating the next generation of physicians and brings a unique perspective through his background in global health and public health. Dr. Carpenter, thank you for joining us today. Could you please introduce yourself to our audience a little bit more and tell us a bit more about your journey into diabetes care?
Sure. Great. Thanks for having me. I grew up in the Bay Area in San Leandro, and after high school, I didn't have a direct pathway into college or further education. And so I got a position at a warehouse in one of our local communities, and then I enrolled at one of our community colleges. And my first class was physiology. And it was at that moment that I fell in love with medicine, academia, and learning. So I continued on at Chabot Junior College for 2 years and then transferred to the University of California, Irvine, where I studied genetics and biology. At the end of my undergraduate career, I had an opportunity to work on an intestinal parasite project in Cameroon, in the north part of Cameroon. And that's what triggered my passion and interest in global health. From there, I did medical school at Albert Einstein College of Medicine in New York City, and then a pediatric residency at University of California, San Francisco. At the end of residency, my wife and I decided that we wanted to dedicate the next several years to full-time global health work. Our first stint was in the Eastern Congo in Goma. And we were working with a local organization called Heal Africa there, helping them with quality improvement in both the neonatal and the pediatric ICU. And then after our time in Congo, we signed up I joined a global health fellowship at Harvard, Partners in Health, Boston Children's, and was positioned in Haiti. And right after we arrived in Haiti, we knew that this was going to be the place that we were going to dedicate the next several years of our careers. And I'll talk a little bit about our first experiences in Haiti and how that transitioned into diabetes care. We were working in a local hospital run by the Ministry of Health north of Port-au-Prince, and they had really great infrastructure, treatment, physicians, staff to be able to care for acute illness. So they could take care of children that had appendicitis or pneumonia or blood infections or brain infections. But after a few months, we started noticing that they didn't have the infrastructure to take care of children with chronic diseases, to be able to provide them with the ongoing support. And there was one patient that was admitted to the ward a few months after I started there who had diabetes, and we didn't have the medical supplies to test for her sugar levels, and we didn't have the medications to treat her for her high glucose levels. We ended up bringing the patient to our home, my wife, kids, and I, and we were treating her and helping her manage her diabetes. And then we had a serendipitous meeting of another physician in Haiti who was adopting a child from Haiti, and that child, through the adoption, was diagnosed with type 1 diabetes. And it was at that meeting we started to think about creating a center for children with chronic diseases, in particular diabetes. And out of those conversations, we came up with the plan for the center and was able to obtain funding. And on the eve of opening up the clinic, this was in December of 2012, we were celebrating with our families on Christmas Eve, and we got a call from the local hospital that there was a child in a coma they thought had diabetes, but they didn't have the ability to check or treat, and they asked if we had our supplies. And we were getting ready to open the clinic. We were opening the clinic on January 2nd, so we had all of our supplies. And Dr. Rick and I went down in the evening of Christmas Eve. We had our glucometers, our insulin, and we were able to figure out that she did, in fact, have diabetes. She was in diabetic ketoacidosis. And we worked all night until Christmas morning, treating her, giving her her insulin. And on Christmas morning, she woke up. And she had been in a coma for about 72 hours. She stayed in the hospital for a few days, and when we opened up the doors to our clinic on January 2nd of 2013, we transferred her in as our first patient, and we have been open ever since.
Wow.
That's an amazing story. It's as Caden said, it's really inspirational to see how you took matters into your own hands and like addressed a prevalent issue in Haiti. So now, kind of connecting to your work in Haiti. So you mentioned that you established a clinic for children with chronic diseases. So in your practice there, what challenges did those families face the most that really surprised you as a caretaker or as a doctor?
Yeah, boy, there are numerous. I think maybe highlighting one of our patients, and now has become one of our friends and colleagues, and she has given us permission to talk about her story. Her name is Micheline, and we met her in 2015. She was a young lady. She was 17 at the time, and she had been diagnosed with diabetes about a year prior to that. Her family was utilizing resources from their family to buy her insulin supplies and her glucometers and her insulin. And that was costing their family about $100 per month. And that was their entire income. They were not able to send their other children to school. They were having to miss meals. They were not able to buy clean water. So it was affecting all of them. And Micheline, at one point, she told her family that she did not want her illness to affect everybody else. And she asked them to stop giving her treatment, to stop checking her sugar levels, to allow her to lay on the couch and allow her to die. And they made that decision as a family. A few days after that decision was made, a man from another community was walking through, and this was in the hills above the area where our clinic was, heard about the story, went and met Micheline, and told her about the clinic. And they brought her down from the mountains and brought her down initially with a horse, and then she was able to get on a motorcycle and came down to the clinic. And I remember the day I first saw her. She was 17 and she weighed 17 kilos, so just under 40 pounds. And at that point, she had resigned that she was going to die. But when she realized that there was care available, I think that it brought her hope again and brought her family hope again. And she stayed in our clinic for several months as she was regaining strength. And about 2 or 3 months into her stay, she was gaining enough energy and she was able to communicate and talk. And at one point, she told our staff that I haven't been able to see for a couple of years. She had developed cataracts. And A few months after that, we had a team from a local organization was visiting Haiti, and they were doing eye surgery for both children and adults. And one of the most beautiful moments of our time working with the clinic was the day Micheline took the eye patches off of herself and was able to see for the first time in a couple of years, and the smile on her face. That was several years ago. Micheline is still coming to our clinic and getting diabetes supplies, and she is just an amazing member of our community.
Wow. And that's something I can resonate with because I actually went to Guatemala last summer where I shadowed medical eye cataract surgery. So exactly the same process that I guess one of your patients have been through. So I definitely know what that process is like and how life changing it can be, how inspiring that one moment can be. And it can really just be a big turning point in one's life. So, like your patient, I'm sure that you guys have definitely guided her along the process and made sure that, she's in a much better place now than, where she was a few years back. And that kind of just ties into our next question of looking ahead, what developments in pediatric diabetes are you most excited about over the next 5 to 10 years that may come through the system?
Yeah, I'm excited about a lot. I'm excited both locally and globally. I'm excited about expansion in diabetes detection, offering services and being able to identify children and adults that have diabetes. I'm excited about diabetes monitoring with continuous glucose monitors. Um, Better tests to monitor disease progression. I'm excited about diabetes treatment with insulin, and none of our patients in Haiti have ever had the opportunity or access to insulin pumps. Excited about that. And I'm excited about future of potential therapies that can either revitalize the insulin producing cells or create insulin producing cells themselves. And I'm pretty far outside of the research realm, but I have colleagues that are in that, and that's a very exciting potential future therapeutic.
Yeah, that sounds really exciting actually, because like I took human physiology last year, and then we learned about how like in type 1 diabetes the body doesn't produce insulin at all. So it sounds really like the idea itself sounds really groundbreaking when you hear that like you can introduce therapies for the body to create its own stem cells. Okay, so now
Yeah, with islet cells in the pancreas, and I wanted to. That was a great point. And so, type 1 diabetes, the patients ultimately don't have enough insulin, and so if they are in Haiti, for example, where it's very politically unstable, there's a lot of violence, there's a lot of crime. There are some times where they don't have access to that insulin. They can't get to the clinic. They can't get down to the local town to take the bus. And if they go days or weeks without insulin, they could get very sick or die. And we have unfortunately had more deaths at our clinic because of lack of being able to just get there to get the medications over the last 8 years than we did in the previous several years because of the political instability. So that's a really good point about the body having a lack of insulin. And
yeah.
I wanted to make another point that is very important with global health is we came up with the idea of the diabetes clinic initially, but everything that we do is because of our partnership with local organizations, local nurses, local doctors, people at the Haitian government. So this is right now, the iteration of the clinic now has really grown because of our local partners. And the day-to-day care that is provided at our clinic is done by doctors and nurses that were born and raised in Haiti. We help support them. We do some mentorship, We do some fundraising, but all of the care and the great care that is taking care of our patients is done by our local providers. I just wanted to make that very clear for your audience that this is really a huge group effort and dedication of many years by our local colleagues.
Yeah, that sounds great. Actually, it's honestly something that our organization really wants to do too. Like we also want to like really involve the public in reaching diabetes supplies or providing diabetes education. And we've also seen that transportation too can be a huge barrier to accessing education and supplies, which is actually a huge reason why we started this podcast, so that like a lot of patients who don't have the facility to physically go to like an educational workshop can still obtain essential information online in like an engaging podcast like format. Okay, so you're mainly a pediatric doctor, right? Like you deal with adolescents and children. So in a clinic, what are some of the first signs that a child or teenager might be struggling with diabetes, even if they seem okay physically or their blood sugar numbers look okay?
Yeah, diabetes care can be challenging. It can be hard. It requires daily, multiple times a day planning around meals, around taking medications, and just that continuous care can be stressful. So I look for signs of anxiety, depression, struggling in school, withdrawal, maybe conflict at home, conflict in school, and in actuality, I almost kind of expect it as patients are going through adolescence, because adolescence is so hard. When you're getting into your teenage years, you want to be independent. You want to have more control over your life. And the rigorous nature of diabetes care can be really challenging. So we just make it a point of really investigating all of those other social and behavioral. All of our children that are at the clinic at Kai Mackinson Clinic are seeing both a social worker and a behavioral health specialist. It is just assumed that our patients are going to need that support. And sometimes they're doing fantastic, and sometimes they need a little extra help. But it is, I think that I'll just stop there.
Yeah, I mean, I could only imagine that there's obviously going to be psychological factors, whether that comes with, transitioning from adolescence to like, early teenage years and beyond. There's obviously going to be transitions there that might affect you both physically, but also psychologically. And also given sort of the difficult political turmoil that, the country experiences amongst many other probable factors, I'm sure that psychological factors do definitely play a role in maybe inducing or possibly even worsening the effects of diabetes or just any other healthcare issues that might come up among those children.
Yeah, it sure does. Our staff at our clinic talk about the frequency that there is a deceased body in the street on their way to work. About having lockdowns and not being able to go home and having to sleep in the clinic, about the threat of gun violence and kidnapping. And so just that kind of pervasive stress and anxiety outside of the home, outside of the medical care is really challenging.
Right. And for me, as someone that wants to enter the psychology field, just a question sort of related to that. So, as a pediatric physician, what are some of the biggest changes you see in diabetes care as children become teenagers and even maybe when they're transitioning to the adulthood stages? What are some psychological aspects of that?
Yeah, I think just being very intentional about the care. Children, whether they're preschool, elementary school, their life is really regulated and directed by their parents or their caregivers in general. And as children start to move into adolescence, they're definitely taking more ownership. And I think just being very intentional with the parents that we need to be able to give adolescents some freedom, some ownership of their care, some power in decision making, but also having some accountability and ensuring that they are getting their insulin and they are checking their glucose levels. And so I think it's a really tricky balance of weighing that independence versus ensuring that they are getting their medications. And so I would say that for us, the most challenging medical management is with our adolescents. If we have a 4-year-old come in that has type 1 diabetes, mom and dad are doing all the checks. They're rigorous, doing great. And then they often do well through school age. And then we have a little dip during adolescence. And then when they get into their early 20s, there's often this ownership over their health again. So I see us as just needing to be the shepherds as they go through their adolescent years to help them.
Yeah, of course. Of course, teenagers and adults they need to learn to like be independent and manage their own issues, their own disease, make sure they get their medications and all that. But as you said, in the case of children, parents are almost always directly involved in the treatment process. So throughout your career dealing with children and their families, what are some of the biggest challenges you see parents face, and what advices make the biggest difference for families? So essentially, what separates families who seem to thrive after like a diagnosis of diabetes versus those who tend to struggle?
I think it would revolve around support. If families have the ability to access care, to access diagnostic tools, glucometers, continuous glucose monitors, have the ability to access their insulins, have their ability to have good trained medical teams to help support them. I really feel like that is the main barrier. I've seen families that do have access from all walks of life do really well. And then families that maybe don't have those opportunities also from all walks of life not do well. So I think it is mainly the access to the supplies, the medicines, the education, and the support systems. Probably the most important.
Right. And now we have a little segment on our podcast titled Myth or Fact, where we're going to be listing 3 statements, and then if you could give us an answer on whether the statement is a myth or a fact and provide maybe a short explanation about it, that would be great. So our
Okay.
first
Is
one,
there any in between? Could it be a
I
myth
think,
and a fact?
right, I think there's some that are pretty self-explanatory. In the past, we've had some that are more 50-50, but I think after hearing them, I think you'd be able to give us a good answer.
Okay.
Yeah, and the first one being stress and emotions can affect blood sugar levels. Myth or fact?
Oh, 100% fact. So stress, anxiety, emotional, physical stress increase your cortisol, which affects your sugar levels. So definitely stress can make many different types of illnesses worse. So, in particular, diabetes. So, that's a great one. That's a fact.
Alrighty.
Okay, so our next myth or fact section or question is: many diabetes-related complications are preventable with early intervention and consistent care. Myth or fact?
Um, I think type 2 diabetes, fact. There is a lot of data about diet, exercise, weight control. So quite a bit of prevention that can be done before you have the diagnosis of prediabetes or even afterwards. So a lot of prevention can be done to limit type 2 diabetes. Type 1 diabetes, so insulin-dependent diabetes, so when your body is destroying your insulin-secreting cells, I think would be myth. But I think prevention in management of your diabetes can prevent the complications. So very good glucose control, a diet that is best for you. So I think we can prevent the long-term complications from type 1 diabetes.
Right. And our last one would be, if you do not have a family history of diabetes, that means that it is harder for you to get diabetes than people who do have genetic histories of diabetes.
Genetics plays a role, and I think it plays a significant role. But there are many patients that I have seen, and many patients that have diabetes, both type 2 and type 1, that don't have a family history. So I think it is important, but also it is very important. Even if you don't have a history of diabetes, it is important to understand the symptoms. And if you have those symptoms, to be able to go and get tested.
Okay, so this is the final segment of our podcast. The next one, it's called Hot Take. So we have four questions lined up for you, and then you have to basically choose one or the other option provided in each question, and then explain why you choose it. So the first hot take is prevention or treatment. If you could only invest in one, which would have the greatest long-term impact on diabetes care?
Wow. That is going to be a tough. Boy, I feel like either one that I pick is going to neglect an entire subset of patients. I think I've got to pick treatment. My pediatrician soul does not like picking that because prevention is always so important. But I feel like if I pick prevention only, I'm going to be neglecting all of my patients that have diabetes. So I'm going to pick treatment. I would love to be able to have treatment that is available to everybody, regardless of socioeconomic status, and treatment that is advanced so that they do not have the burden of injections multiple times a day, checking multiple times a day. So I want an ideal treatment plan. So I'll go with that. That was a tough question.
Yeah, no kidding. And the second one is, what's more valuable for a patient? Having more diabetes data or reducing the mental load of living with diabetes, and why?
And when you say diabetes data, is that the finger checks that they do so frequently?
Yeah, I believe so. Yes, that's what we're
okay. Yeah, I think that, again, I think referring back to our other question about the difficulties with adolescents at management, I think decreasing the mental load, the mental stress of diabetes. Children and adolescents and adults can have diabetes and live amazing, fruitful, active, enjoyable lives and be able to ultimately do whatever they want. I've had children that have diabetes that have gone on to play professional sports and great careers all throughout many different job sectors. And we had one of our young ladies in at Kai Mackinson, who was pretty sick with diabetes for several years, and she was able to turn the corner. And what she always wanted to do is just have a beautiful family and have kids. And she had twins at one point, and then another baby. So, yeah.
Okay, the next hot take is socioeconomic or medical. Which of these barriers are the biggest barriers to diabetes care?
I think probably, I think socioeconomic. I think the availability, both in the United States and Haiti, I think it is socioeconomic barriers and access to care. Maybe in a society that has medical care for all. Some of our neighbors to the north and across the Atlantic who have access to care, it could be the medical part, but I think for us and Haiti, it would be socioeconomic. Just being able to get to the care, access it, and maintain that continuity.
Right. And just like a quick question on the side, you said, you already have all this foundation that you've laid out in Haiti. So how often, if any, do you frequently visit Haiti to maybe check up on that clinic that, you have helped establish?
Yeah. When we first started the clinic from 2013 until 15, I was going to Haiti almost every month. And then 2015 to 2018, once everything was established, it was going really well, I was visiting a couple of times a year. Since 2018, there has been so much political instability and gang violence, kidnappings, that the clinic has actually asked me not to come because it would put them at risk. Seeing a person from the outside come would put both the staff at risk, and they're worried that it would put me at risk. I do meet with the clinic staff every month, and we have our monthly board meetings for the clinic, and we communicate very often. So that allows us to maintain that connection. But the clinic itself does very fine with the Haitian leadership that they have.
Oh, that's really great to hear. I'm glad that, there's always alternatives around it, even if you're not physically able to be there. And so the last hot take is improving diabetes education versus developing a new diabetes medication. Which one would have a greater global impact?
Greater global impact. I think I'm going to go with education to identify patients. When we were looking at our data of the patients that were coming to our clinic, we were seeing almost all of our patients were school age or older. And we think that we were missing a large subset of our population in the preschool and early school age. And we think we were missing it because they were not getting diagnosed appropriately. You would maybe have a 2-year-old that comes to the clinic with vomiting and dehydration. And common things being common, you might think that they had a virus or a bug, but do not have both the education in the communities or community health workers or staff at the hospital to think about diabetes. So I think I might expand education so that we can identify the patients that need support for their diabetes care.
Okay, so with that essentially concludes this podcast. So before we finish, there's one question we ask all of the guests that come to the Diabetes Roundtable, and that is, if there was one thing you wish everyone would understand about diabetes, what would that one thing be?
I think it's got to be that patients with diabetes can live a very full, wonderful, engaging life. That Diabetes requires conscientious planning about diet and your medications. But once you get to that point, you can do whatever your heart desires with your career, with your relationships, with education. I think that many people that are initially diagnosed have that fear that is going to limit their lives. And I try to really emphasize that that this is just part of our life, and we're going to get through it, and you're going to have a very impactful and full life.
Yeah, I mean, that's obviously a great message to give out to the world, I think. Just giving hope is definitely a big aspect that boosts, people with diabetes, both psychologically and gives them that, motivation or understanding that, it is possible to, live a fulfilling life, even with this, disease that you're going to live with for the rest of your life. But I do believe it's a very important. I mean, personally, my dad has diabetes, so just seeing him manage it well, I think is pretty inspiring to me. And to everyone else in the world that may have it, I think it's really just great that, there's people that can give them hope and help them see the brighter side of things, like you just mentioned. So, yeah, without any more to say, we thank you so much for joining us on this episode of our Diabetes Roundtable podcast. Thank you for your time and the information you have given us. I'm sure the audience really is grateful for what you provided us with and obviously for your time today. So once again, I wanted to thank you. And we can now conclude this episode of Diabetes Roundtable. Thank you very much.
Thank you. Thanks for having me.